a brief summary. So let's begin. As we all know, the efficiency of in vitro fertilization is limited by the functional and kinetic properties of the spermatozoa. In the 90s, different manipulation techniques were to increase the chance of a spermatozoon to reach the oolemma and fertilize it naturally. In a first approach called zona drilling or zona parcel dissection, embryologists used an acid, an enzyme, or a needle to partially thin or open the zona pellucida. A second approach was to aspirate multiple spermatozoa from a sperm drop with a large pipette and inject them in the perivitelline space. The latter technique was named subzonal injection. Both techniques resulted in an increased fertilization rate, but also in a very high polyspermia rate. It was during one of those SUSI procedures that by accident a sperm cell was injected into the oocyte. And this oocyte showed to be normally fertilized the next day, as published by the group of Palermo and colleagues from Brussels. And as defined by this group, ICSI is a procedure that entails the deposition of a single spermatozoon directly into the cytoplasm of the oocyte, thus bypassing the zona pellucida and the oolemma. It is obvious that ICSI is a high-precision procedure through which an oocyte can be fertilized independently of the morphology and/or motility of the single spermatozoon injected. Let's now focus on the indications and outcomes for ICSI. ICSI was an immense breakthrough for treatment of patients suffering from male factor infertility. Patients suffering from severe oligospermia and later even azoospermia by retrieving sperm cells from the epididymis or testes were offered a chance to father a child. Since then, ICSI usage for non-male factor, however, is increasing globally. ICSI is being used for unexplained infertility, poor quality oocyte, low oocyte yield, advanced maternal age, prior fertilization failure with conventional IVF, pre-implantation genetic testing, fertilization after IVM, and fertilization of cryopreserved oocytes and oocyte donation cycles. Some clinics also opt for ICSI for all cases. The data from Europe, as presented by the ESHRE-AMI Consortium in 2020, show again the ongoing trend towards more ICSI usage, accounting for more than 70% of the cycles performed. So are we doing a good job? The ICMAR data on the year 2016, as presented at the ESHRE meeting 2020, are global data for non-donor cycles and do not include the data from China. They clearly show a delivery rate of 19.2% per aspiration, both for ICSI and IVF. Next question then to be asked is if ICSI is safe. Multiple studies have been published on the health of the children born. Unfortunately, there are many pitfalls and inconsistencies in these study designs. But globally, the data provide reassuring evidence regarding the health of ICSI children for male indications. The data show that there is a higher risk of preterm birth and small for gestational age, as well as an increased risk for congenital malformations, chromosome aberrations, less favorable cardiometabolic outcomes. These risks are at least partially related to parental infertility and can also result in transgenerational inheritance of the infertility, so sons inheriting the poor sperm qualities from their fathers. Studies on the long-term follow-up of ICSI children, so on adults, are so far scarce. So who benefits from ICSI in the non-male factor group? The MSERM committee analyzed data on usage of ICSI in the non-male factor group and found that ICSI may be of benefit for select patients with pre-implantation genetic testing for monogenic disease or previously cryopreserved oocytes. For all other indications such as unexplained infertility, poor quality oocyte, low oocyte yield, advanced maternal age, fertilization after IVM, ICSI seem not to result in better outcomes. ICSI for patients with previous failed or no fertilization cycles, there however it can improve the fertilization rate. So how can an oocyte be fertilized by ICSI? Let's remind ourselves of just what a specialized and fascinating mechanism fertilization process is. Freshly ejaculated sperm are unable or poorly able to fertilize. Rather, they must first undergo a series of changes known collectively as capacitation. Capacitation is associated with removal of adherent seminal plasma proteins, reorganization of plasma membrane lipids and proteins. The sperm head carries the acrosome, a lysosome that is packed with zona-digesting enzymes. After the acrosome reaction, the enzymes are released and the zona pellucida is dissolved. The acrosome will react with the PVS and sperm and egg membrane will fuse. Upon binding of a sperm, the egg will then rapidly undergo a number of metabolic and physical changes that we collectively call egg activation. Prominent effects include rise in intracellular concentration of calcium, completion of second meiotic division, and cortical reaction. The latter is a massive exocytosis of cortical granules seen shortly after sperm oocyte fusion. These proteases alter the structure of the zona pellucida and it will be impenetrable for other sperm cells. The male pronucleus will be formed and DNA will decondense. The male pronucleus will then migrate to the female one and they will fuse to form the diploid nucleus. The second polar body is then extruded. Now, in ICSI, the initial steps of fertilization are bypassed, namely the movement to, the binding to, and the penetration of the zona pellucida, as well as the fusion with the oolemma. But the following biological processes still take place, and these are the rise in calcium in the ooplasm, the oocyte activation, the formation of the male pronucleus and DNA decondensation, migration of the male pronucleus and the pronuclei fusion, and formation of the diploid nucleus, and of course the extrusion of the second polar body. Two steps in the ICSI process are crucial, and these are the aspiration of the cytoplasm into the ICSI pipette to break the oolemma and to induce oocyte activation. The second one is the immobilization of the sperm, so that the sperm can release oocyte activating factors into the ooplasm, and this will also induce a rise in calcium. Let's now look at the practical aspects of ICSI in the laboratory, more particularly the sperm prep for ICSI. Sperm preparation technique should remove all seminal fluid, remove all non-sperm cells, isolate morphologically normal and motile sperm, will support capacitation and result in the reduction of DNA fragmentation. Sperm preparation technique should isolate and select viable spermatozoa with intact functional and genetic properties, normal morphology with minimal DNA damage, intact cell membranes with functional binding properties. There is a range of sperm preparation techniques available, and I do not have the time to address all in detail, so I focus on the three simplest and most widely used: wash and concentration, swim up, and density gradient. Diluting semen with culture media and centrifuging is by far the simplest method, but because it compacts the healthy sperm into a pellet with non-sperm cells and poor quality and dead sperms, there is a real risk of reactive oxygen species damaging the healthy sperm. This, together with the fact that there is no selective process to refine the population of sperm, it will mean then that the wash and concentration should be a last resort and not generally recommended. The swim up and other sperm migration techniques rely on motility, so are best for samples of generally high quality, and this is not always the case in ICSI samples. As for the wash and concentration, it is generally not recommended that sperm samples be washed and then a swim up is performed, but rather medium is layered over whole semen and the collected sperm is washed. Density gradient separates cells by their density and will result in an optimal yield, a clean fraction of highly motile spermatozoa. The formation of reactive oxygen species is significantly reduced. The choice of sperm preparation methods depends on the characteristic of the semen sample. Concentration and motility are within the normal ranges, then direct swim-up technique can be used. For significantly OAT samples, which is mostly the case in ICSI, density gradient centrifugation or a modified density gradient layer step is preferred, since density gradient centrifugation leads to a higher recovery rate of motile sperm cells, and this compared to the swim-up technique. The DCG can be modified to address the issues of each individual specimen, and it is the method of choice for sperm prep in the majority of ART and andrology labs. In case of testicular biopsies, the spermatozoa need to be isolated from the testicular tubuli. This can be done in a mechanical way by milking with needles, mixing through a tissue grinder, or slitting with sterile glass slides. The tubular material can also be digested with enzymes like DNase 1 and collagenase type 4. This method will also result in the lysis of excessive red blood cells. It is very useful in case of non-obstructive azoospermia, and this in addition to mechanical methods. If a good number of spermatozoa are present, we can centrifuge the cell suspension with culture media, or we can even apply a mini density gradient centrifugation. The supernatant is removed and the pellets are resuspended in fresh culture media. Let's now focus on the denudation of the oocyte. The removal of the cumulus complex and corona radiata surrounding the oocyte is necessary to easily fix the oocyte on the holding pipette, to also have a good view during the injection of the zona pellucida, the oolemma and the ooplasm, and of course to check the quality and maturity of the oocyte. We generally use the enzyme hyaluronidase, and this is found in high concentration in the acrosome of most mammalian spermatozoa. This can be recombinant or bovine or ovine of origin. I will describe a typical denudation by using cumulase as an example. We have to prepare first of all our denudation pipettes. Then we will pre-equilibrate the medium containing the enzyme for 2 hours at 37 degrees. This is of course according to the IFU of the supplier. When the 2 hours have passed, we will take 0.3 to 0.5 ml and transfer it into a multi-well dish. One of several oocyte cumulus complexes are placed in the first well with a large pipette. After 60 seconds, the cumulus oophorus complexes are gently aspirated up and down in a denudation pipette and transferred to a second well with buffered medium. The remaining cumulus cells are removed by gently aspirating the oocytes up and down with a smaller diameter. Once the cells are removed, we wash the oocyte thoroughly by transferring them between several wells of culture medium to remove all traces of the enzyme. The oocytes are then transferred to the culture dish and placed in individual microdrops covered with pre-equilibrated liquid oil and cultured until ICSI is performed. Care needs to be taken that temperature, osmolality, pH are stable throughout this first manipulation step, and gentle pipetting is performed to avoid mechanical stress on the oocytes. Washing of oocytes after denudation to remove all traces of enzyme is key, and of course witnessing of the ID should be ensured during all denudation steps and culture steps. The choice of a denudation enzyme can be based on the following. On the one hand, animal-derived products have limited purity and accidental transmission of pathogens cannot be fully excluded. On the other hand, studies show that the use of recombinant enzyme cumulase for denudation resulted in lower oocyte degeneration rates and better embryo qualities. After denudation, we can score maturity and quality of the oocytes. ICSI is generally performed on metaphase 2 oocytes. ICSI on in vitro matured M1 to M2 oocytes can be done but will result in a reduced fertilization rate. high aneuploidy rate and low pregnancy rates, and very low ongoing pregnancy rates. As for the quality of the oocyte, the Istanbul Consensus and the work of Rubini and colleagues list the following abnormalities as to have a negative influence on the outcomes and therefore should not be inseminated. The giant oocyte, as you can see in the picture the top left, is a possible source of diagenic triploidy. The abnormal first large polar body, but not fragmented, is pictured top right. There is a risk of aneuploidy in this oocyte. Oocytes with large perivitellin spaces, increased cytoplasmic granularity, and large vacuoles persisting past syngamy. These are also not to be inseminated, are linked, or they will result in poor outcomes. Oocytes with smooth endoplasmic reticulum aggregates or discs, however, can result in normal embryos and can be injected, as demonstrated by the work of Soumopoulou. Let's now look at the hardware, the equipment and pipettes and so forth that we need for our ICSIs. I've listed here the minimal equipment that needs to be in place to perform high-quality ICSI procedures. So we need a flow cabinet type 2, stereo microscope with heated stage, incubators, non-gassed and CO2 gassed, inverted microscope with micromanipulators, 2 injectors, this could be air or oil, anti-vibration table, low energy laser system, a screen, stable heated stage and or a heated crib, no direct airflow above the micromanipulators, and of course, often forgotten, adjustable chairs, because ergonomics are very important for a healthy working position. As for the micromanipulation pipettes, we need high quality. These are sterile and tested and defined for use in IVF. The typical size of the holding pipette ranges from 100 to 120 micrometers outer diameter. And an ICSI pipette generally has a controlled inner diameter of 4 to 6 micrometer. A new pipette must be used for each patient. A witnessing system also needs to be in place. This to avoid adverse events and ensure traceability of all process steps and batch and stock controls. Let's now focus in depth on the ICSI procedure itself. First, we will focus on the dish preparation for our ICSIs. We will use a standard ICSI dish, 9 mm height dish, and that is really designed for IVF. Do not use the lid of the dish because it could be toxic. Then we need oocyte sperm and or sperm slow PVP drops, and they should be easily distinguished and spaced to avoid merging and mixing. The layout should help keep track of which oocytes have been injected, so the drops should be numbered. They should not be too close to the dish edge and interfere with the tool. Equilibrate these dishes for a minimum of 30 minutes in a non-gassed incubator before starting the ICSI procedure. Let's have a look at the traditional ICSI dish preparation. I'm showing you here 2 examples of a dish layout, but there are many variations to this. Best is to place drops of 10 to 20 microliter of HEPAs and or MOPS buffered medium supplemented with HSA as centrally as possible, so 1 drop per oocyte. Then we will add the PVP drops and we will add extra drops of the HEPAs and or MOPS buffer for sperm collection and or for washing of pipettes. We will overlay with 6 ml of pre-warmed mineral oil for embryo culture. And then we will equilibrate those dishes for a minimum of 30 minutes in a non-gassed incubator. A sperm slow dish has a slightly different design. Here again, we will use 10 to 20 microliter HEPAs and or MOPS buffered media drops for our oocytes, but we will place a PVP drop as well as a sperm slow drop. We will move practically during the ICSIing, we will move from the sperm slow into the PVP, so they should not be too far away from each other. Again, we will make an overlay with oil and install them, equilibrate them in a non-gassed incubator for at least 30 minutes. The Pixie dish has preloaded dry hyaluronan microdots for advanced sperm selection. We rehydrate by adding 5 microliter of buffered media, pulling into an elongated teardrop shape, taking care not to touch the microdots. We will cover quickly with oil to avoid evaporation. We will equilibrate around 10 minutes in a non-gassed incubator. And when ICSI will commence, we will add the sperm at the tip of the drop furthest from the microdot, so they can swim toward the hyaluronan drop, as you can see in the image on the top right. For epididymal and testicular sperm samples, an extra drop with the sample is placed under oil, and sperm cells are collected individually from this prepped sample and then brought into a collection drop before performing the ICSI itself. Before we start, we will clean the eyepieces, the manipulators, the holding system, in this all in view of the COVID-19 pandemic. We will check the laser alignment and function, and we will check temperature on the heated stage. We will install holding an ICSI pipette, and we will check our injectors. The tip of the ICSI pipette should be orientated slightly downwards, so in order to immobilize easily. Next, we will label the ICSI dish with patient's name and number the oocyte drops and move the gametes into the dish. And of course, here we need witnessing, so in order not to have a mix-up of gametes. We will bring the ICSI dish to the inverted microscope and prime and test the ICSI and holding pipette in the extra wash drop by aspirating some medium in and out of the pipettes. The ICSI technique consists of 3 steps. The first one is selecting the spermatozoa, and we will go into detail in a little bit on how to do that. We will then immobilize the spermatozoa, and this we do by touching the flagellum of the spermatozoa, so fixing it between the pipette and the ICSI dish. We will align the spermatozoa with the pipette and then aspirate it. We will stabilize the spermatozoa in the tip of the ICSI pipette, and we will move to the oocyte drop. In the oocyte drop, we will orientate and hold the oocyte with the holding pipette. We will bring the pipette in the equatorial plane. We'll focus on the oolemma, and we will bring the spermatozoa to the tip of the pipette. Slowly, we will push the ICSI pipette through the zona pellucida in the oocyte. The third step consists in aspirating the cytoplasm and in re-injecting the cytoplasm plus the spermatozoa. We will then slowly retract the pipette from the oocyte, staying in a nice horizontal plane. We will stop aspirating the oocyte with the holding pipette, and we will remove it from the holding pipette. So let's watch the complete ICSI procedure with all steps in detail. Aspiration of the cytoplasm, re-injection of the cytoplasm plus the sperm, retraction of the pipette, slowly, gentle, and then removing of the oocyte from the holding pipette. Following injection, oocytes should be washed and returned to culture in a new equilibrated labeled dish. The oocytes should be washed through drops of culture media and incubated overnight in a gassed incubator. It is important to witness the move from ICSI dish to culture dish and note all details on the ICSI procedure and the oocyte quality in patient's dossier. During the ICSI procedure, the real-time selection of spermatozoa is an important step. Today we can use different techniques. To select viable from dead spermatozoa in a pool of immotile spermatozoa, we can use the following methods. We can perform a viability test on each individual sperm cell, just prior to the ICSI. There is, for example, the HOS test, the hypoosmotic swelling test, where live spermatozoa will curl their flagellum when placed in hyperosmotic solution. We can check the viability also by touching the tail with the pipette for reaction of the flagellum. This is the mechanical method. And a third one is to laser the tail at the end of the flagellum. So they're checking again for reaction, yes or no. The fourth method is exposing the spermatozoa to a range of substances. These include methylxanthines like pentoxifenone and theophylline, caffeine, or myo-inositol. The pentoxifenone is the most known, the most widely used one, and this will stimulate motility. It is key, of course, that after incubation there is a washing step and that this substance is not injected as such into the oocyte. We can also do a real-time selection for morphology. At normal magnification, we have to select the spermatozoa under morphological appearance. There is a correlation between the head shape and aneuploidy. The majority of large-headed spermatozoa are diploid. 25% of spermatozoa with amorphous heads, round heads and elongated heads have chromosomal abnormalities. Globosospermia have high DNA fragmentation and no acrosome, so artificial activation could be an option for these samples. And lastly, the presence of cytoplasmic remnants is a sign of nuclear immaturity. Another approach is the IMSI, the intracytoplasmic morphologically selected sperm injection technique at high magnification, 6,300 times magnification. Here we use enhanced optics to examine the ultrastructure of sperm, and we look for the presence of vacuoles, as suggested by Citi and colleagues, and in this way to improve pregnancy rates and reduce miscarriage rate. A Cochrane review of randomized controlled trials does, however, not support the clinical use of IMSI and found the evidence that improves clinical pregnancy of very low quality. A later review suggested that IMSI may be effective in overcoming later paternal effects like blastocyst formation and implantation. Another option for individual sperm selection is hyaluronan binding. If sperm cells bind to hyaluronan, it will reflect cellular maturity, reduce risk for DNA fragmentation or aneuploidy, and increase chromatin integrity. A large study in the UK showed a significant reduction in miscarriages when using pixie dish for sperm selection, particularly in older women. The live birth rate was slightly higher but not statistically significant. But for individual couples, lowering the risk of miscarriage is very relevant. It should be noted that the study was performed on a broad population and sperm selection may not be relevant for all couples. There are two systems for hyaluronan binding. One is the pixie dish, and you can see that one on the left. As discussed before, once the plaque of the pixie dish is rehydrated, sperm can be added and allowed to swim across the plaque. Those expressing receptors to hyaluronan may bind to the surface of the dish in the circular plaque and then be aspirated into a ICSI pipette. In sperm flow, shown on the right, sperm are introduced into a drop of the hyaluronan-rich medium, and if expressing receptors, they will get trapped in the gel matrix and lose progressive motility and shudder on the spot. And this way we then can pick those spermatozoa, go to the PVP, immobilize, and use them for injection. Now the next day after our ICSIs, we will check fertilization by the presence of 2 PNs and 2 polar bodies in the manipulated oocytes. Roughly 1% of the oocytes will show 1 PN oocytes. These 1 PNs should preferably not be transferred, since they can be haploid because of parthenogenesis, or they show asynchronous PN formation, or they had PN fusion, so they are diploid. But we do know from studies that if they are diploid, they have a higher aneuploidy rate than normal 2 PNs. Failed fertilization can also occur, and in less than 1% there is a total failure to fertilize. It is really difficult to pinpoint the exact cause because it could be oocyte and or sperm related. I will now quickly touch on some factors that influence the quality of your ICSI and its outcomes. Multiple factors will influence each step of the fertilization and culture process in our labs. It is our professional task to ensure that the stress on the gametes and the embryos is minimalized during these different steps. The temperature is a key one, and it needs to be stable between the limits of 36.7 and 37 degrees. And this to avoid instability of the meiotic spindle in the oocyte. So a uniformly heated stage, like for example the thermosafe, is mandatory. Equipment and culture systems need to be validated, maintained and monitored rigorously to avoid any sudden stress on gametes and embryos. Now let's look at some technical steps in your ICSI that could optimize your ICSI procedure and outcomes. For example, is it important to have the portal body at 6 or 12 o'clock? It is your choice. The portal body is not a good indicator for the meiotic spindle, so you can put it at 6 or at 12 o'clock without interfering with the outcomes. The opening of the ICSI pipette, shall it be towards or away from the portal body? Preferably away from the portal body, in case the meiotic spindle is there, but there's no proof for better or poorer results though. Shall I use a large or a small pipette for injection? Well, we know that larger pipettes may harm cytoskeleton, which in turn might have consequences on blastocyst formation. Shall we use spiked or non-spiked pipettes? Well, again, this is your choice, but be aware, the spike pipette can damage the opposite oolemma of the oocyte. What about rupture of the oolemma? Is that an indicator for success? Yes, it can be an indicator for successful injection. No or immediate rupture or large funnel formation is associated with higher degeneration and lower fertilization rate. A difficult injection can sometimes be avoided by laser-assisted ICSI. And this is where you laser the zona pellucida first, and then you enter through this opening into the oocyte. Multiple studies focused on the effect of timing and ICSI outcomes, but with conflicting outcomes. It now seems that fertilization rates, pregnancy rates and ongoing pregnancy rates are better when ICSI is performed less than 38 hours post-ACG injection, less than 3 hours after egg collection, less than 4 hours after denudation, and the sperm preparation is ideally performed in less than 2 hours before the actual ICSI. A recent study by Maguli and colleagues showed that there is no influence of procedural timings of operators on the outcomes. If you want to know more about these, please join us in the Journal Club next Friday, where Dr. Maguli will go into detail about this study that was recently published in Human Reproduction. It is very important that ICSI operators are well trained in a stepwise manner to perform well. For this, it is essential that their outcomes are logged, including their timings for each ICSI. Several indicators to check if we are doing well have been suggested by the Vienna Consensus Committee in 2017. I've listed them here, and please understand that they are suggestions. It's up to each individual laboratory to define their proper KPIs and reference population that they want to monitor. When you look at these KPIs, there will be a delay in effect on the outcomes of 2 to 3 weeks for the lab KPIs like fertilization and oocyte damage rate, and 4 to 6 weeks for the clinical KPIs like pregnancy rate. And even longer, of course, for the cumulative pregnancy rate and healthy baby at home rate. But they are, however, essential that you monitor those qualities with these KPIs to see if the ICSI in your lab and clinic is done well, as well as the quality of the operators. Continual monitoring of competency is also key, and the just mentioned KPIs can be used for just this. Teagues et al. Demonstrate here that the increased ICSI operator experience is associated with higher fertilization rate, sustained implantation rates and lower likelihood of failed FERT and usable blastocyst development. Before I summarize, I feel we must also look at the future of ICSI. The piezo injection system, where the piezo effect, that is the crystal deformation in response to an externally applied voltage, will propel a microinjection needle tip forward in a precise and very rapid movement. It is being applied in multiple laboratories around the globe now. A recent review by Fuji et al. Showed that with this technique less oocytes are damaged, embryo utilization rates are better, and the health of the children is fine. There is also a drive towards automation of ICSI. Until now, the following techniques that I describe here are still in the developmental and design phase and/or experimental phase. Microfluidic denudation of oocytes on the left, microfluidic single sperm selection on the right, robotic sperm immobilization. There's also oocyte trapping with microfluids, real-time electrical resistance measurements of oocytes, and there is also the use of artificial intelligence in the development of automated ICSI. But hey, the future will show it, the future will tell. Okay, I will now summarize the key points. ICSI is a high-precision assisted reproduction laboratory technique. It requires additional laboratory experience, resources, effort, and time. It is being used more and more globally for non-male indications. High-quality equipment, media, and pipettes are to be used. Preparation and selection of spermatozoa and oocytes is important. Stress to the gametes should be kept to a minimum, and all lab conditions should be monitored continuously. Witnessing steps are to be implemented to avoid adverse events. And training in ICSI and monitoring of operator competence is key to success.